OBGYN and sexual health. Ectopic pregnancy. When we say an ectopic pregnancy, it means an extrauterine pregnancy. So a pregnancy, that means the implantation can be intrauterine, that is inside the uterus, or it can be outside the uterus. If it's inside the uterus, then it is known as intrauterine pregnancy. If it is outside the uterus, that's when we call it as an ectopic pregnancy. The most common site for an ectopic pregnancy, that means out of the uterus, is the fallopian tube. Is the fallopian tube where it is very commonly seen. What are the risk factors? There are various risk factors like an PID or a previous history of ectopic pregnancy, or anything which is causing strictures like previous manipulation in the pelvis by surgery, doing in tubal surgery or in pelvic surgery, or in presence of endometriosis, or an assisted fertilization, that is nothing but in vitro fertilization, which is very commonly seen. Anyone who is on an intrauterine contraceptive devices like an copper T, anyone who is on OCP pills, especially the progesterone only pills, any congenital abnormalities or the variants of the uterus if it is present, or inside the uterus there is a cyst or there is a tumor or there is an ovarian cyst or a tumor. All of these are the risk factors for an ectopic pregnancy. What are the clinical features? In an emergency department, if there is a female who is in a childbearing age, that is important, who is a female who is in a childbearing age and is sexually active and presents with an abdominal pain, it is an presentation of an ectopic pregnancy until and unless proven otherwise. So in your differential diagnosis, it should be at the topmost if it's a female childbearing age, sexually active, presents with an abdominal pain. There are plenty of clinical features what I have written here. Most of these clinical features are because of the pregnancy itself. A normal intrauterine pregnancy also can present with similar symptoms like amenorrhea, missed periods are seen in normal pregnancy, breast tenderness, or GI symptoms like nausea and vomiting, urinary symptoms like an increased frequency of urination. All these have been seen in normal pregnancy also. What helps you to differentiate from a normal from that of the ectopic pregnancy? For example, shoulder tip pain, vaginal bleeding. It might be an intrauterine also vaginal bleeding resulting in an abortion. So you need to be careful at that point of time. Any abdominal or pelvic tenderness is present, or an cervical muscle tenderness, shock or orthostatic hypotension. It is highly suggestive of an ectopic pregnancy, specifically ruptured ectopic pregnancy. Only ruptured ectopic pregnancies, when the ectopic pregnancy ruptures, there is oozing of the blood or there is spillage of the blood into the peritoneal cavity. That causes hemodynamic instability. That causes peritonitis and pain to the shoulder tip. So these are the parameters what you need to look out for. Investigation wise, first of all, you need to confirm whether there is a pregnancy or not. So you get an UPT test done, or you can get an serum beta HCG levels done. For example, urine sample is difficult to give for the patient. At that point of time, you can just collect a blood sample and get an beta HCG done. This just helps you to tell that whether the lady is pregnant or not pregnant. But it will not tell you whether the pregnancy is intrauterine or is an ectopic pregnancy. For that, you need an ultrasound scan done. Someone presenting for the first time, you do an EPT, it is positive. It can still be an intrauterine pregnancy. So be careful at that point of time. Always or do not forget to get and resuscitate, because if they are rhesus negative, then you might have to give an anti-D immunoglobulins for that female. Serial beta HCG and progesterone levels when it will be required. You get an ultrasound scan done. You do not see an sac, extrauterine or intrauterine. You're not seeing this sac at all. At that point of time, serial beta HCG and progesterone levels to monitor that patient will be required. If it's a true ectopic pregnancy and there is a bleeding, getting a clotting profile is important because this patient goes for the surgery. So how do you manage a ruptured ectopic? That is the true emergency to the emergency department. A ruptured ectopic is managed like any other emergencies with an ABCD approach. If the female is if the female is rhesus negative, I'm just talking about the female being rhesus negative here. If the female is rhesus negative, that is enough for you to go ahead and give an anti-D immunoglobulins in those stages and urgently involve the gynecology. If the patient is not an ruptured ectopic, that means the patient is hemodynamically stable. It is not ruptured as of now. Depending on the beta HCG levels, few literature says less than 5,000, few literature says less than 3,000. So it is a call taken by the gynecologist rather than by us. Okay. So if the beta HCG level is on the lower side, generally they usually treat it with medical management by giving an methotrexate. If it is on the higher side, that's when they usually do an dilatation and curettage. That is dilatation and basically removing the products of consumption. Hemodynamically unstable patients requires an laparotomy. Laparotomy along complete removal of the ovary or in partial removal of the ovary, that call will be taken by the gynecologist, not by us. So what is the stepwise manner what you need to go? This is important because most of your questions will be what is the next step they will be asking rather than asking what is the definitive treatment. So first is airway and breathing. Usually it will be normal in this individual. Circulation, because there is a spillage of blood into the peritoneal cavity if there is a rupture of the ectopic pregnancy. So like any other hemorrhage, we will be treating with to getting in two large IV bore cannulas. Get all the blood investigations which are required to activate a major hemorrhage protocol. Activate the major hemorrhage protocol and start giving the blood and blood products. If these are not available, most of the time will not be readily available blood and blood products because they have to be procured from the blood bank. In the meanwhile, to bridge the time, you can give crystalloids fluids like NS or Hartmann's can be given. Hartmann's will be the preferred one. So once you start the resuscitation, then you involve the gynecological team. If the patient is resist negative, then you give anti-D immunoglobulins. So in this sequential manner, you need to select. If they already started the IV fluids and they have activated the major hemorrhage protocol, then the next step will be to involve the gynecological team so that they can take up for the operation theater. If you already involve the gynecology team, then the next step will be to see whether resist negative or positive. If negative, needs anti-D immunoglobulins. If the patient is completely hemodynamically stable, then all these steps will not be required. You are just seeing resist negative, then give anti-T immunoglobulins and refer to the gynecological team. So remember the steps, usually they ask next step rather than the definitive management. Definitive management is referring to the gynecological team. They will decide on laparotomy what needs to be done. Sorry, I said here removal of the ovaries is not the removal of the ovaries, it's the fallopian tube or along with the fallopian tube whether the ovary needs to be removed. That call will be taken by them depending on where is the ectopic pregnancy. Most of the time it is in the fallopian tube. Pelvic inflammatory disease. Pelvic inflammatory disease means there is an infection in the pelvis. What is happening? Most of the time, that is 90% of the time, this is because of sexually transmitted organisms like chlamydia is the most commonest, followed by gonococcal, or it can be any other sexually transmitted organism. Most common is chlamydia and gonococcal. Out of this, if you have to select, always select chlamydia over and gonococcal infection. Non-sexually transmitted only accounts for 10%. Most of the time, the situation is some instrumentation has been done in the pelvis, like post-surgery, if they, for example, hysterectomy, they might have done, or some procedure might have been performed. After that, if they develop, then it might be a non-sexually transmitted, like from an E. coli, group B streptococci, or Gardnerella infection, or bacteria, any other infections can be. Remember, it is only the small portions. Usually, it is a post-surgical event what you'll be having. So most of the time, it is a sexually transmitted disease. What are the clinical features? There is an inflammation going on in the pelvis. So they'll be having pain in the lower abdomen. And on palpation, it will be tender. And usually it will be bilaterally. Entire lower abdomen will be tender when you are palpating. Some discharge might be present from the vagina or the cervix. Because it is an infection which is causing the inflammation, there will be fever present. And sometimes along with the discharge, there might be vaginal bleeding. Deep dyspareunia means whenever they have intercourse, they have the pain. When you're doing an PV examination, cervical motion will cause tenderness, and adnexia, that is above or on the side of the cervix, if you're going, they might have tenderness and they might feel a mass. If the mass is felt, then you need to suspect there might be an abscess in this individual. What are the investigations? If there is a discharge which is there, always get a swab done. Especially an endocervical swab is preferred for both chlamydial and gonococcal. You will be getting swabs. Rule out an ectopic pregnancy by getting an UPT done. Other blood investigations is like any other infection what you are getting. These are helpful for you to basically make a diagnosis, but none of this will specifically tell you this patient has a pelvic inflammatory disease. This will support your diagnosis. They are not specific. So get inflammatory markers like ESR, CRP, and WBCs. Why we are worried about pelvic inflammatory disease? We want to treat this aggressively. Why do we treat it aggressively? Because of the complications. They can have infertility, especially very important in young individuals. It can lead to ectopic pregnancy. One of the risk factors for ectopic pregnancy is PID. It can cause chronic pain. It can cause peritonitis, infection spreading into the peritoneal cavity, or it can end up forming an abscess. Because of these complications, we want to treat anyone who is having a pelvic inflammatory disease aggressively by giving antibiotics. While giving antibiotics, first we need to take a call whether I need to admit this patient so that I can give an IV antibiotics, or I can treat this patient in the outpatient basis. So when do we treat an inpatient basis? First, we need to see. Whenever the patient is having a high grade fever that is greater than 38 degrees Celsius, whenever there is an tubio-ovarian abscess, or any signs of pelvic peritonitis is present, or the patient has an pelvic inflammatory disease in pregnancy. In all these scenarios, we go ahead and admit the patient and treat with IV antibiotics. Uh, the IV antibiotics, what is given is ceftriaxone 2 grams OD, metronidazole 500 mg TDS IV, along with doxycycline. This is given per orally 100 mg PD. Do you need to remember the antibiotics? Yes. In this scenario, yes, you need to remember the antibiotics and the doses. They can test you in the exam. What about the outpatient basis? If none of these are present, then yes, you can confidently treat this patient in the outpatient basis. The first line of drugs here is ceftriaxone 1 gram is a single shot what you're giving in the emergency department. Afterwards, you're prescribing two oral antibiotics. One is doxycycline, another one is metronidazole. For 14 days, you're prescribing. If you can remember the first line, that will be sufficient from the exam point of view. You should remember 90% of the time it is a sexually transmitted disease. So screening for the partners is helpful, or you need to screen the partners here. So last 6 months, whoever the partners are for that particular female needs to be screened. How do you screen? By referring to the genitourinary medicine. So via gum clinic, the short form for genitourinary medicine clinic is the gum clinic. So via the gum clinic, you will be referring them or you will be tracing them and tracking them. Endometriosis. Endometrial tissue, which is commonly seen intrauterine. That means inside the uterus, it is commonly seen. It is intrauterine, that is inside the uterus, it is commonly seen. But sometimes it might be out of the uterus, as you're seeing here. So somewhere in the ovaries, it can be present. It might be outside of the uterus, it can be present. Then we call it as an endometriosis. So it becomes an endometriosis at that point of time. What are the clinical features? Because the endometrial tissue is outside the uterus, whenever they are having periods, they will be having quite a bit of pain. This is known as severe dysmenorrhea. Dysmenorrhea means pain while having the periods. Deep dyspareunia means pain during the intercourse. And chronic pelvic pains they might end up with. Ovulation pain, that is the mid-cycle when the ovulation happens, they'll be having quite a bit of pain. It can lead to infertility, and cyclical menstrual symptoms can appear in this individual. How do you treat it in the emergency department? First of all, you need to exclude the ectopic pregnancy diagnosis. Once you are excluded, then you are doing a symptomatic management. That is giving NSAIDs and paracetamol. Just deal with the pain what they are presented. So most of the time, they come to the emergency department with the pain. So from emergency point of view, you are just managing the pain. After managing the pain, just refer to the gynecologist on OPD basis. Remember that endometriosis cannot be diagnosed. It can be only be suspected in the emergency department. For diagnosis, you need to do an laparoscopy and direct visualization of the pelvis and take a sample, histopathology report of that suggestive of an endometrial tissue. Then only it suggests that it is an endometriosis. We can only suspect in the emergency department. So someone comes with the severe dysmenorrhea and pain during the ovulation. There might be some history of infertility or some history of chronic pelvic pain. Then what you do? You just give the painkillers, make sure the patient is hemodynamically stable, and ask them to follow up with the gynecologist on the OPD basis. Ruptured ovarian cyst. A cyst which is present in the ovaries can get ruptured. Okay, most of the time the pain will be quite localized and it will not be very severe. So we'll just be treating symptomatically and refer to the gynecologist. The true emergency is ovarian torsion. It's the counterpart for an testicular torsion. So testicular torsion and ovarian torsion has similar pathophysiology here. What happens basically? Basically, the ovary should be in a large size. Large size when it happens, whenever it has a cyst. So it has a cyst which has resulted in the increase in size of the ovary. Increase in the size of the ovary predisposes it to rotate. Whenever it rotates, it causes compromise of the blood supply and it goes infarction. So any organ which goes in infarction, you'll have severe pain. So they will be presenting with unilateral. That means either on the left side of the lower abdomen or the right side of the lower abdomen. acute onset of pain, which is very severe, they present to the ED department. Sometimes what happens, it can detours itself and the blood supply might be retained and the patient might be completely asymptomatic by the time you go and see the patient. That can very well happen in these scenarios. How do you diagnose these patients? You diagnose a patient by getting a transvaginal ultrasound. Okay, that will help you to diagnose. So admit this individual, involve the gynecologist, do an pain management. So these are the steps what you're doing. So first, manage the pain, involve the gynecologist, admit it. These are the steps what you need to remember. Dysmenorrhea. Dysmenorrhea is painful menstruation. So painful menstruation can be without any underlying cause, then we call it as a primary, or with an underlying cause because it has a fibroid uterus or it has an endometriosis. We do not know the underlying cause. Whatever might be the cause, if some patient presents with an dysmenorrhea, how do you treat it? You treat it by giving an prostaglandin inhibitors. NSAIDs are prostaglandin inhibitors. Out of all the NSAIDs, the preferred NSAID is mefenamic acid. Mefenamic acid has better, has and is shown to be acting better in managing the pain compared to any other NSAIDs like in ketorolac you give it or ibuprofen you give it or diclofenac you give it. It is better than any other NSAIDs. So preferably you are giving mefenamic acid for these patients. Fibroid. What is fibroid? Fibroid is nothing but a smooth muscle and fibrous connective tissue. Fibrous connective tissue and smooth muscle. So depending on the positions, they have various names. It can be an pedunculate submucosal, or it can be a fundal subserosal or submucosal, or it might be subserosal or intramural. It all depends on the histopathology or laparoscopic findings where you're finding this mass. This is a mass of smooth muscle tissue and fibrous connective tissue. So classically, they present with menorrhea, that means increased bleeding during the menstruation, pain during the menstruation, and pain during the intercourse. These are the common symptoms what they'll be having. How do you manage? Usually the painkillers. But in pregnancy, what happens? It can go infarction. Pregnancy, the uterus enlarges, the blood supply might be compromised by the fibroid, resulting in infarction. This is known as red degeneration. A known case of fibroid in pregnancy comes with a severe pain. Suspect it might be a red degeneration. Sometimes it can undergo a torsion resulting in blood supply compromise and might have sudden severe pain. In all these circumstances, we can just guess it. We cannot come up with a definitive diagnosis. We are just referring to the gynecologist here and doing a pain management. That is a symptomatic management. Corpus luteal cyst rupture. Corpus luteum is formed when a mature ovarian follicle ruptures and releases an ovum, resulting in the formation of a corpus luteum. So a mature ovarian follicle ruptures to release the ova, then it becomes a corpus luteal follicle. What happens here? Whenever it ruptures, okay, sometimes there will be only minimum. Most of the time, it will be only minimal amount of fluid which will be going into the peritoneal cavity. Rarely, a frank hemorrhage can happen. If there is a frank hemorrhage, the patient might have severe pain. So how do you guess it? You guess it whenever they present with mid-cycle, second half of the menstrual cycle, they present with abdominal pain. If the loss of blood is significant, they can even present with a syncope, and these patients can have postural hypotension. How do you manage the emergency department? So there is an hemorrhagic shock kind of if it all the patient is hemodynamically unstable. So fluid resuscitation, you're doing it, and admission will be required if the patient is gone into a shock, which is a rare thing to happen. Most of the time, they'll be having a mild pain. Simple analgesias like NSAIDs and paracetamol should be sufficient. Menorrhagia. Menorrhagia means increased bleeding. Increased bleeding, we have already discussed. It might be because of fibroid, it might be because of endometriosis, PID, presence of polyps, some metabolic disorders like hypothyroidism, presence of an intrauterine intrauterine device like an copper T. All this can cause increased bleeding during menstruation, known as menorrhagia. DUP. What is DUP? When you do not know a cause for the increased bleeding. Usually they will be having heavy irregular periods they'll be having without any obvious pathology. You cannot find out what is the underlying cause. There's no obvious pathology is present. That's when you call it as an DUB, which stands for dysfunctional uterine bleeding. Post-menopausal bleeding. Okay. Usually after menopause, they shouldn't be having any menstruation. They shouldn't be having any PV bleed. If they have a PV bleed, most of the time, because of decrease in the levels of hormones in postmenopausal women, they can lead to an atrophic vaginitis. Sometimes it might be endometrial polyp. Sometimes it might be because of the fibroids, what we have discussed already. Any cancer that is an endometrial, cervical, or vaginal cancer, it might be. Okay. Or it might be because of endometrial hyperplasia. This is important for us. So any female postmenopausal she is and presents with a PE bleed to the emergency department, first of all, make sure she is stable. Most of the time they'll be stable. If there is increased bleeding, you can stop with the tranexamic acid by giving a simple tranexamic acid will be helpful here. Endometrial hyperplasia should be first differential diagnosis for you. So what you'll be doing, you will be referring to the gynae team here. So gynae team, what they will do, they get an ultrasound scan done to measure the endometrial thickness. If the endometrial thickness is significant, they go ahead and get a sample of endometrium to see whether it is cancer or not. A biopsy will be taken if it is significantly on the thicker side. So the question is whether we need to get an ultrasound scan done directly from the emergency department. No, not required. So refer to the OBGYN team on an OPD basis, but it should be an urgent referral. So usually within 1 or 2 days, you need to get them an appointment. So an gynecologist sees them, gets an ultrasound scan done to measure the endometrial thickness. If the endometrial thickness is significant, they'll go ahead and get an biopsy done to see whether it is a cancer or not, that is endometrial carcinoma or not. So from the emergency department, if a postmenopausal woman comes with an PV bleed, what you will do, you'll refer to the gynecologist. Why you'll be referring? Because this might be an endometrial carcinoma. So you're referring to the gynecologist. Why are you referring to the gynecologist? So that they can get an ultrasound scan done. Ultrasound scan done to see what? Endometrial thickness. If the endometrial thickness is significant, they get a biopsy done to see whether it is a cancer or not. Bleeding in pregnancy now. Bleeding in pregnancy can be divided depending on the trimesters, first, second, or third trimesters. In first trimester, spontaneous miscarriages, ectopic pregnancy, and trophoblastic diseases are the common. So ectopic pregnancy, we are already discussed. We'll be discussing about spontaneous miscarriages and trophoblastic diseases. In second pregnancy, that is at the early part of the second pregnancy, it can still be in spontaneous miscarriage or trophoblastic disease, but much more commoner in the later part of the second trimester and first part of the third trimester is placenta abruptio and placenta previa. The rare causes in the third trimester bleeding is show of pregnancy and vasa previa. First, let us see the spontaneous miscarriage. Spontaneous miscarriage can be different types depending on what is the presentation. It can be a threatened miscarriages, also known as abortion. Do not get confused. They mean one and the same. So it can be an threatened abortion. When do we call it as a threatened abortion? They present with an PV bleed. Okay, when you do an pelvic examination, then when we do an perspectivum examination, the internal os is closed. In this individual, the os is closed here. And the fetus is viable. That means fetus is alive. That is known as threatened abortion. What about inevitable abortion? They again present with an PV bleed. You do a perspectivum examination. The internal os is open here. That means this pregnancy is inevitable. So the fetus, the products of conception, the parts of the fetus is known as products of conception will come out eventually. They not come out, still they are completely inside uterus, but they will come out eventually because the internal os is open. Incomplete abortion. As the name suggests itself, it's an incomplete what you're thinking about. So they present with again PV bleed, internal os is open here. And when you do a perspectivum examination, few products of conceptions can be seen coming out of the cervix. Few products of conceptions are intrauterine here. That's why it is an incomplete abortion. Some has already happened. Some products of conception has already come out. Some are still inside. As some are still inside, we call it as an incomplete abortion. When do we call it as a complete abortion? When the uterus is completely empty. All the products of conceptions have come out. They will be complaining that, yes, there was a bleed, but I can make out some tissue-like material also has come out. And when you do an ultrasound scan, the uterus is empty. That is suggestive of a complete abortion. What is missed abortion? Missed abortion is they do not know itself what has happened. They do not present with any PV bleed or anything. They routinely get an ultrasound scan done and they find out that the fetus is dead here. It's already dead. So there was no PV bleed, internal os was closed, but the fetus is already dead. When it got died, we don't know, we missed it. So that's why it is known as missed abortion. What are the clinical features? Clinical features, they usually present with an vaginal bleed, as I discussed, unless it is a missed abortion. Most of the other types of abortions present with an PV bleed and abdominal pain. In all of these circumstances, the products of conceptions can come out. Once they are coming out, they can get stuck in the cervix. If they get stuck in the cervix, what happens? The vagal tone increases. Increase in vagal tone will result in severe bradycardia, which will eventually result in severe hypotension. So if these patients are in shock, what do you need to suspect? You're suspecting it most likely it is because of an cervical shock. So this is a cervical shock because of increase in vagal tone resulting in bradycardia and hypotension. I'll be discussing about the steps in coming up slides. What are the investigations you are getting it done? First of all, make sure it is a pregnancy if they're not sure whether they're pregnant or not. Get in serum beta IgG or UPT to make sure it is a pregnancy. Then get an ultrasound scan done to see whether it's an intrauterine or extrauterine. It can be still an ectopic pregnancy. So ultrasound scan will be helpful. Getting a per speculum examination will tell you internal os is closed or not, but ultrasound scan also can tell you if the internal os is closed or not. That will be helpful. Resuscitate. Resuscitate is important. If it is negative, you might have to give an anti-T immunoglobulins, especially if they're presenting after 12 weeks of gestational age. If they're presenting within 12 weeks, after 12 weeks, you have to give it. Within 12 weeks, if they're presenting, if a procedure is required to evacuate the products of consumption, that is dilatation and curettage is required. At that point of time, yes, you need to give anti-D immunoglobulins. These patients rarely will require any resuscitation. Usually it will be a cervical shock. There will not be enough blood loss for you to do an resuscitation or cause this hemodynamic instability requiring an resuscitation. Nevertheless, it is recommended that you get a full blood count, clotting profile, and cross matching. Because if you're doing a dilatation curettage, they might bleed heavily. At that point of time, these investigations will be helpful to resuscitate. So what are the steps? What do you need to go? If the patient is hemodynamically unstable. If he's unstable in circulation, always first thing and cervical shock in abortions or miscarriages. So do an per speculum examination. Look for anything stuck in the cervix, remove it. That should be your first step. Then like any other hemorrhage we are talking about, hemorrhagic shock, you're treating or managing in the similar manner. Same thing we discussed for the ectopic pregnancy. It is the same thing what I have written here. Nothing special has been mentioned. After that, if there is still active bleed is present, ergometrin can be given. That is 500 micrograms intramuscularly you're giving it. Involve the gynecological team immediately. If they are Rh negative and non-immune, then usually anti-T immunoglobulins will be required. I'll be discussing about this in coming up slides in depth. Next one is gestational trophoblastic disease. So this is an ovum what you're having. Okay, this entire thing what you're having is known as blastocele. Okay, the outer layer what you are having is known as trophoblast. The inner cells what you're seeing, the blue color cells what you're seeing are known as embryoblast. The outer cells what you're seeing, the trophoblast what I said, they can start multiplying. Okay, they can start multiplying violently, resulting in a tumor. So this tumor can be a benign, then we call it as an hybridiform mole. It can be an cancerous, then we call it as an choriocarcinoma. How do they present to the ED department? They present with the symptoms of increased nausea and vomiting, what you commonly see in pregnancy. So exaggerated symptoms, multiple episodes of vomiting, nausea, upper abdominal pain, those kind of symptoms. Initially, they'll be having. Eventually, around the end of the first trimester and beginning of the second trimester, they present with an vaginal bleed. And there might be passage of the tissue-like materials which appears like an frog eggs, frog spawn appearance, we call it. And when you do an ultrasound scan done, it shows an Sony-Strom appearance. So remember, they can come up with an passing tissue-like materials. This appears like a frog egg. When you get an ultrasound scan done, it appears like an Sony-Storm appearance. So what do you do in the emergency department? You basically give fluids if they are dehydrated or if they are in the shock, give analgesias and immediately involve the gynecologist to evacuate the uterus. This is not viable. This is a tumor. It might be benign or malignant, so you need to remove it. This is known as gestational trophoblastic disease, a broad terminology in that you have an choriocarcinoma as well as hybridiform mole, depending on whether it is benign or malignant. Antepartum hemorrhages. Antepartum hemorrhages, that means bleeding after 24 weeks of gestation. We call it as an antepartum hemorrhages. It can be because of two most commonest causes are placenta abruptio and placenta previa. followed by vasa previa. Then we have uterine rupture. Then we have bleeding from the lower genital tract. But the commonest one are the first two. Let us see each one of these now. Placenta abruptio. Placenta abruptio, the risk factors are preeclampsia, any previous history of placenta abruptio, any any trauma, smoking, multiparity. What happens here? The placenta which is there gets detached. Whenever it gets detached, it starts bleeding. So you can see here there is a blood which is getting accumulated. Some of it will come out through the PV and they present with an PV bleed. Remember that most of the blood will be concealed. So what the PV bleed is, they might come and say some 5 ml has come out, a few drops have come out. The patient might be in the shock because most of the blood is still intrauterine. It is concealed here. It is just separated and got concealed there. Only few drops have come out through the PV. So you shouldn't be correlating with amount of blood loss through the PV. You need to get an ultrasound scan done that will suggest you how much concealed bleeding has already happened. And these patients will have pain. This is important. When you're doing an examination, they will have tenderness. This is also important. These are the two symptoms which will help you to differentiate from an placenta previa clinically. So vaginal bleeding, abdominal pain, and tenderness, what they present with. Placenta previa. Placenta previa, what happens in placenta previa? First, let us see the risk factors in the placenta previa. Maternal age being more than 35 years, or high parity, or previous placenta previa, twin pregnancy, uterine abnormalities, like in previous C-section or fibroids. All this can cause placenta previa. In placenta previa, what you can see here is the placenta is just over the os, that is just over the cervix. Whenever the cervix dilates a little bit, what will cause? It will cause rupture of the vessels here, resulting in bleeding. And this bleeding is painless and there will be no tenderness on palpation. And usually it will be bright color, fresh blood, what will be present. Vasa previa, it's a rare condition. It is not very commonly seen. It is a rare condition. What happens in this condition? In this condition, the fetal blood vessels grows within the membrane and over the internal os. So the fetal blood vessels are grown within the membranes and over the internal os here. So hemorrhages can occur whenever there is rupture of the membranes, and there might be extensive loss of fluid whenever there is a rupture of the membranes, which happens just before the pregnancy. Which happens just before the delivery. Treatment management. For all the three, I'm talking about placenta previa, abruptio placenta, as well as vasa previa. So get full blood count clotting and fibrinogen because they are in hemorrhagic shock. Cross blood matching, rhesus status, ABCD approach needs to be done. Anti-D immunoglobulins needs to be given if they are in rhesus negative. So how we will go? Airway breathing usually will be fine. In circulation. In circulation, if you have blood products, give blood products if they are in shock. If not, give IV fluids if blood products are not immediately available. Then get the rhesus state done. It is important. Along with it, we always get an Kleho's test done. Why is it important to get a Kleho's test done? Kleho's test will precisely tell you how much anti-D immunoglobulins to be given if they are rhesus negative. Again, I'll be discussing about this in coming up slides. Next one is hyperemesis gravidarum. Hyperemesis gravidarum is severe symptoms of nausea and vomiting, what you see in pregnancy. So previously, it was known as early morning sickness. Early morning sickness terminology is no longer used. They are using terminology as nausea and vomiting of pregnancy. Most of the females will have certain amount of nausea and vomiting in their pregnancy. If these symptoms are quite severe, then only we call it as an hyperemesis gravidarum. Previously, it was thought it correlates directly with the beta hCG levels. Now they are thinking it is not with the beta hCG levels. It is more correlates with GDF15. Okay, this is the GDF16. Whenever they are very hypersensitive to the increased level of GDF15, they result in severe symptoms of nausea and vomiting of pregnancy. The blood investigation, because they are losing a lot of fluids, they can have electrolyte imbalance can be seen. Hematocrit values can be on the higher side. LFT, because of the vomiting, they can go in thiamine deficiency and end up having Wernicke's encephalopathy. That's why we are getting an LFT done. Beta HCG levels are also important in this individual. Why beta HCG? First of all, you need to confirm it is a pregnancy. If they're not got an ultrasound scan done, then get an ultrasound scan done to see whether it's an intrauterine or an ectopic pregnancy. So transvaginal ultrasound done under the under the specialist team why you are getting, and if it is already confirmed, then it is not required. If it is not confirmed, then transvaginal ultrasound scan will be helpful here. First thing to see whether it is intrauterine. If it's intrauterine, is it because of multiple pregnancy, for example, a twin pregnancy or triplets, or is it because of a molar pregnancy, gestational trophoblastic disease, which I told you they present with severe symptoms of nausea and vomiting initially, and later on at the end of the first trimester or starting of the second trimester, they present usually with PV bleed and some tissue-like materials which appears like a frog spawn. How do you quantify how severe is the hyperemesis gravidarum? You do an scoring. Okay, this scoring is recommended by RCOG. So this is the one what they usually test in the exam. If they test you, it's known as PUQE, pregnancy unique quantification of emesis. This is known as. What they do, they basically ask you three questions. Depending on the three questions, they score you, and it will be mild, moderate, or severe. The first question is, since how long you have been having this nausea or feeling of having sickness? That means you feel like vomiting. Since how long you're having this feeling? Have you vomited, or you are just having the feeling of throwing? You are having the feeling of throwing up, or have you thrown up? That means have you actually vomited? How many times you have been having retching or dry hips? You're not vomiting, but you're retching. You feel like something is coming out. It is metallic taste. That means you're retching the acids which are there in your tummy. These are the three main questions what they'll be asking. This is another system to assess that is known as HELP, which stands for hyperemesis level prediction. When do we admit this individual? We admit this individual if the score is on the higher side, or doesn't matter what the score is if they're having any complications. Complications, for example, wernicke's encephalopathy they are having because of thiamine deficiency, electrolyte abnormalities are present, or the patient is in shock or the patient is having severe dehydration, then you need to admit this patient. Inability to tolerate any oral fluid. You give some fluid, they vomit. If they're not able to take it orally, then you have to admit them so that you can give some IV fluids. Unresponsive to outpatient basis. Okay, outpatient basis, you have started management. For example, GPS started management and they're not responding, then you have to admit. Clinical dehydration, weight loss for more than 5% of the weight loss is present, or they are having some comorbidities. For example, urinary tract infection, epilepsy, diabetes, HIV, hypoaldosteronism, psychiatric disorders. Why are we worried about this comorbidities? Because if they do not take the medications on regular basis, because they are having nausea and vomiting, whenever they take tablet, they are vomiting out. So it can, for example, if this anti-epileptic medications, if they do not take, they can end up having an epilepsy. If the sugar medications, if they're not able to take it, they might end up going into diabetic ketoacidosis. For that particular reason, you're concerned because of the comorbidities what are present and the tablets what they need to take on a timely manner. So you go ahead and admit these patients. What is the treatment here? Treatment here, give IV fluids. Preferred one here is normal saline, along with adding potassium chloride to it, because they're vomiting from the abdomen. In abdomen, you have HCl here. Okay. There will be loss of hydrogen ions. Along with it, there will be loss of potassium ions also. It is not actually loss of potassium ions. What actually happens is because there is loss of hydrogen ions, which is present here. Intracellularly, what will happen? They'll exchange for the potassium channels what are there intracellularly with the potassium what is present intravascularly. So this potassium goes into the cell, resulting in hypokalemia. That's why potassium chloride is recommended. These are the latest guidelines. They can go into thiamine deficiency. So give prophylactic thiamine for all the patients who presents with nausea and vomiting of pregnancy, or they present with a severe form of hyperemesis gravidarum. Antiemetic medications. These are important you need to be aware of. First line antiemetic medications usually used is cyclizine or doxylamine along with pyridoxine. These are the preferred ones. There are other first line antiemetic medications also, like promethazine, prochlorperazine, chlorpromazine. These are all first line antiemetic medications. Second line medications which we usually commonly use, like ondansetron, metoclopramide, and domperidone. What are the third line of antiemetic medications? Is the hydrocortisone. We as an emergency physician shouldn't give hydrocortisone. This should be given only by OBGYN or on the advice of OBGYN. If you feel this patient is severely dehydrated, they will be predisposed to venothromboembolism. That's why it is recommended start on low molecular weight heparin If they are clinically severely dehydrated, then only you're starting on normal craft weight heparin, as in prophylaxis for venous thromboembolism can happen because of severe dehydration. Just a second. What are the complications? Because they are continuously vomiting, the mucosal layer of the esophagus can get damaged, resulting in an medullary weave tear. Thiamine deficiency can happen, resulting in Wernicke's encephalopathy. Electrolyte imbalances, especially hyponatremia, can happen. If you correct the sodium levels spontaneously or very rapidly, can result in central pontine myelosis. Other vitamin B12 and vitamin B6 deficiency are also been noted in these individuals. If it is severe dehydration, severe electrolyte imbalance, and malnourishment is happening, fetal intra-growth retardation can happen. Venous thromboembolism mainly is directly correlated to the amount of dehydration what the patient is having. Preeclampsia and eclampsia, important topic once again. Let us see the definition of preeclampsia and eclampsia. Gestational hypertension. When do we call it as in gestational hypertension? Not an essential hypertension which we commonly see in the individual. We call it as in gestational hypertension whenever the systolic blood pressure is more than 140 or the diastolic pressure is more than 190. This is a new onset. New onset after 20 weeks of gestation, then we call it as in gestational hypertension. If this gestational hypertension is associated with significant proteinuria, when do we call it as significant? If there is presence of 0.3 grams over 24 hours in the urine, if there is presence of 0.3 grams of proteins over 24 hours sample what you have collected, then it becomes significant proteinuria. When do we call it as in severe preeclampsia? If preeclampsia is associated with headaches, these headaches are recurrent, severe, ongoing headaches. So it can be an ongoing headache presentation to the ED department or recurrence of severe headaches. Visual disturbances. GI symptoms like nausea, vomiting, and epigastric pain. Severe hypertension along with oliguria. Severe, we call it in the situation of a preeclampsia whenever it is more than systolic, more than 160, or the diastolic more than 110. One of this is satisfied, that is enough to call it as a severe hypertension. Or the patient is going into a complications like an HELP syndrome, where you will be seeing hemolysis of the RBCs, elevated liver enzymes, and low platelet count. It's a mnemonic actually. HELP is a mnemonic, where H stands for hemolysis, where EL stands for elevated liver enzymes, where LP stands for low platelet count. When do we call it as an eclampsia? Whenever a preeclampsia is associated with a convulsions, then we call it as an eclampsia. That is nothing but seizures, convulsions they are having. What are the risk factors? You need to remembering the high risk factors which are important. For example, hypertension in previous pregnancies is a known case of chronic kidney disease, SLE or antiphospholipid syndrome, any type of diabetes mellitus, chronic hypertension. These are all high risk. Moderate risk is first pregnancy or the age more than 40, previous pregnancy interval is more than 10 years. So the first was like at 30 years and second is at 40 years. Then it becomes obese individual where the BMI is more than 35 before getting pregnant or just at the time of the booking. Family history of preeclampsia or multiple pregnancies. These are all moderate risk factors. What are the investigations? Investigations, urine dipstick becomes important because we are seeing further proteinuria in this individual. Full blood count, clotting profile screening, because they can go into various complications, which I'll be discussing in coming up slides. They can go into acute renal failure. They can have a left rearrange going into an HELP syndrome. That's why it is important to get LFT and monitor the fetus. The preeclampsia can lead to intrauterine fetal retardation, growth retardation, intrauterine fetal growth retardation. It can happen, or it can happen and spontaneous miscarriages also. For that reason, fetal monitoring by ultrasound or doing an cardio topography is important here. How do you manage? So first of all, in preeclampsia, the priority needs to be given for the antihypertensive medications. In the second step, if the patient is having severe preeclampsia, then you are giving magnesium sulfate. The patient is actively seizing. Then the first step becomes giving magnesium sulfate. The second step is to reduce the blood pressure. If the patient is not actively seizing, it becomes inverse order. We give antihypertensive medications first in preeclampsia, followed by if the patient is in severe preeclampsia. For example, they are having a headache, they are having nausea, vomiting, and abdominal pain. That circumstances, you have to give magnesium sulfate. Here, giving here magnesium sulfate prophylactically. because severe preeclampsia doesn't take much time to develop into an eclampsia. When do we admit? The presentation itself, the blood pressure is on the higher side. That is more than systolic, more than 160, and diastolic more than 110. Go ahead and admit. If the blood pressure is between 140 by 90 and between this, what I've told, that is 159 and 109, admit if you're worried about the well-being of the woman or the baby. You're seeing there is a complication like an HELP which is developing, or you're seeing there is an intrauterine growth retardation which can happen or which is happening. At that point of time, you go ahead and admit. To reduce the blood pressure, your target of the blood pressure is to get the blood pressure below 140 by 90. So you're using antihypertensive medications whenever the blood pressure is more than 140 by 90. The preferred one which can be given IV is labetalol. The next line of drug, in spite of giving labetalol, if the blood pressure is not coming down, then you can give hydralazine because it is available in IV form. Nifedipine and methyl-dopa both are available in peroral. You can give if the patient is stable enough to take it orally. Nifedipine and methyl-dopa. For eclampsia and preeclampsia, eclampsia and severe preeclampsia, as I told you, we need to give magnesium sulfate. First, you give bolus of 4 grams of IV over 5 to 15 minutes. Then you start an infusion of 1 gram per hour for 24 hours. If the patient is having eclampsia and you are given a bolus, still it has not subsided, the convulsions are continuing. At that point of time, you can keep on giving boluses till the seizure subsides. Usually you give the first dose, doesn't subside. Second dose doesn't subside. Then you need to think this might not be an eclampsia. This might be something else going on. Do not use other antiepileptic medications as an alternative to treat the eclampsia. Always stick to magnesium sulfate. What is the definitive management for a severe preeclampsia or an eclampsia? Is to deliver. Okay, deliver the fetus. That is the definitive management. Having said that, in after delivery, in first 24 to 48 hours, almost 44% of the cases with eclampsia have been reported. Okay, so delivery itself is definitely, yes, all the literature says that, but post-delivery, can you see an eclampsia? Yes, post-delivery also you can see an eclampsia, especially in first few days, 1, 2, 3 days after delivery, you can see an eclampsia. Remember that part. What are the complications? There are various complications which can happen. As I told you, in liver, it can lead to an HELP syndrome. Okay, and it can cause jaundice. In CNS, it can cause intracranial bleed or cortical blindness, retinal edema and blindness. It can cause respiratory pulmonary edema, cardiac failure, acute renal injury or acute renal failure can happen. DIC is one of the known complications which can occur because of preeclampsia, severe preeclampsia or eclampsia. Placenta abruption infraction, one of the risk factors is having preeclampsia. Fetus, as I told you, intrauterine growth retardation. Deaths can happen. Premature deliveries can happen. Now we are talking about rhesus prophylaxis. That is nothing but giving anti-D immunoglobulins. When do we give anti-D immunoglobulins? That is before birth I'm talking about. Whenever there is a sensitizing episode. What is sensitizing episode? An episode where you're suspecting the fetal blood might have mixed with the maternal blood. That is known as sensitizing episode. So any trauma to the abdomen, any antepartum hemorrhages like placenta previa and placenta abruptio, any intrauterine deaths, any invasive procedures, it might be diagnostic or therapeutic invasive procedures, ectopic pregnancies, spontaneous miscarriages. In spontaneous miscarriages, for all pregnancies more than 12 weeks of gestation or less than 12 weeks of gestation, if they are having, some intervention is required to evacuate the uterus, then only you are giving it. Remember that. Same thing holds good for threatened abortion also. That means in threatened abortion, more than 12 weeks, everyone gets an anti-D immunoglobulins. Less than 12 weeks, if there is a heavy bleeding or associated with abdominal pain, then only you are giving, because it's a threatened abortion. You will not be evacuating because the fetus is still viable in threatened abortion. Whenever there is a therapeutic termination of the pregnancy is required or external cephalic version, it is done whenever there is a breech presentation. Whenever there is a breech presentation, they might try an external cephalic version in the third trimester. These are all known as sensitizing episodes where you need to give an anti-D immunoglobulins if the female is rhesus negative. What if the father is also rhesus negative? Still you go ahead and give it. The three main or few of the reasons why you need to give it. You're not sure the father who is there is the biological father or not. The father might not be immediately available for you to check for his rhesus state. For these two particular reasons, if the mother is rhesus negative, you directly go ahead and give an anti-D immunoglobulins. You do not wait for, or you do not do an spy work to find out who is the biological father, take his blood sample. It might be too late. For that particular reason, we go ahead, if the mother is rhesus negative, and go ahead and give an anti-D immunoglobulins. This is according to the RCOG. Routine antenatal prophylaxis is given whenever the mom is rhesus negative, when at 28 weeks and 34 weeks of gestation. Prophylactic administration following an sensitizing episode. This is important. This is more what we are worried as an emergency physicians. It should be given within 72 hours of the sensitizing event, or can be offered up to 10 days after the sensitizing event also. What is the doses? If they are less than 20 weeks of gestation, 250 international units. More than 20 weeks of gestation, 500 international units. Along with it, you are getting a Clohas test. Why are you giving a Clohas test? If the anti-D immunoglobulins more need to be given, Clohas test will tell you exactly how much more needs to be given. So that's the reason Clohas test needs to be done. Following a delivery, we usually give 500 international units if the mom is rhesus negative, and we again get a Clohas test to find out if more anti-D immunoglobulins needs to be given. Sometimes in the emergency department, a female can deliver. Most of the time, a normal delivery, you do not do anything, you just cut the cord. Everything else happens naturally. But sometimes some complications you need to be aware of. Two important complications what you need to be aware of is, one is cord prolapse, another one is shoulder dystocia. Cord prolapse. As you're seeing, the cord has come out into the vagina, but the fetus is still inside uterus. So what you'll be doing? You shouldn't be touching the cord. So why you shouldn't be touching the cord? You shouldn't be handling or touching the cord. Why? If you touch the cord, it will go into the spasm, which can cause decreased blood supply to the fetus. And once it comes into the external environment, usually external environment will be less than 38 degrees Celsius, it can go into the spasm. So as an emergency physician, your duty is to place back this cord into the cavity, into the vaginal cavity. How do you do it? Place the patient in lithotomy position. So it might go by itself due to the gravity. The another thing what you can do is the presenting part, you can push the presenting part inside a little bit. That can drag the cord inside into the vaginal cavity. So you want to keep it in the vaginal cavity and refer to the gynecologist. Another one complication what you need to be aware of is shoulder dystocia. Okay, shoulder dystocia, what we'll be doing? The first step is place the patient in lithotomy position. In lithotomy position, still they are not able to do it, then you can do an episiotomy. Episiotomy is just basically making a small incision here to make more space so the shoulder comes out. Still that is not working. Then what you'll be doing? Then you will be giving an suprapubic pressure as shown here in this picture, and you will be moving the head towards the mom's anus. Okay, so you're moving the head towards the mom's anus and giving a suprapubic pressure should help you to deliver the shoulder of the fetus. Postpartum hemorrhages. Postpartum hemorrhages, as you can see here, there are various risk factors like placenta previa, abruptio, accreta, multiple pregnancies, preeclampsia, gestational hypertension, previous postpartum hemorrhages, hemophilias, and anticoagulant use. All of these are risk factors. What are the causes? So postpartum hemorrhages can be classified into primary and secondary. Primary, we call it if it happens within 24 hours of delivery. After 24 hours, up to 12 weeks, that is up to 3 months, we call it as a secondary postpartum hemorrhage. Primary postpartum hemorrhage, most of the time, it is because of uterine atony. Okay, followed by retained placenta, it might be genital tract trauma because due to the delivery, okay, or it might be an DIC, disseminated intravascular coagulopathy. Secondary post hemorrhages, most of the time it is because of the infections. And most of this infection is because of the retained products of conception. All the products, some part of the, for example, some part of the placenta might be still intrauterine, resulting in infection. Or just that being intrauterine itself can cause bleeding. Or it might be genital tract trauma due to the delivery, or it might be a trophoblastic disease, or it might be a DIC. So the primary most commonest cause is uterine atony. Secondary, the most commonest cause is infection. What do you need to remember? How do you manage? Like any emergency, you will be going with an ABCDE approach. Immediately involve the obstetric team. But if it is an primary postpartum hemorrhage. What is this? Uterine atony. The tone of the uterus is lost here. That's why they are profusely bleeding. To increase the tone of the uterus, you do a massage. This is known as bimanual uterine compression. Do it in this manner. Okay, so you put an fist inside the vaginal cavity and you kind of massage it, and suprapubically also you kind of massage it in this manner what's shown in the picture. This is known as bimanual uterine compression. Rub the uterine fundus, that might be helpful. Always empty the bladder. This is an important step before you do an bimanual uterine compression. Empty the bladder. If required, catheterize the patient, empty the bladder. Most of the time we catheterize, empty the bladder, then do an bimanual uterine compression. If that is not working, then you can use oxytocin or ergometrin IV can be given. If you're suspecting an secondary postpartum hemorrhage because they are presented after 24 hours, start them on IV antibiotics because infection is the most common. Most of the time, it is a primary postpartum hemorrhages that we have. Primary postpartum hemorrhages they'll be having. You will be first catheterizing them, empty the bladder, bimanual uterine compression. If not helpful, then you will be going with the drugs like oxytocin or ergometrin can be given, like carboprost, mioprost, the various drugs which can be used. You will be following the hospital protocols. Uterine rupture. Uterine rupture can happen because of a trauma itself, or blunt trauma to the abdomen can result in a uterine rupture, but it is rare. Okay. If it happens, it is a high risk for the mortality for both the mother as well as the fetus. Okay, high risk for mortality will be there. What are the risk factors? Previous C-section. Because they have made an insertion, here the fibrous tissue has developed, so the uterus strength has reduced. So they can rupture at the site of the insertion where they had it because of the previous C-section. Or the fetus is in large size. The fetus is large size. Because of that, it can cause pressure over the uterus, resulting in a rupture with even and trivial trauma can occur. How do they present with? As the uterus has ruptured, as the uterus has ruptured, they'll be having a persistent abdominal pain. So the main complaint here is persistent abdominal pain. When you palpate, you can palpate the uterine defect and you can usually make out or feel the fetus parts. Head, where is the head? Where is the hand? You can hold the hand, you can hold the legs. Easily you will be able to palpate and they will be having severe bleed. Severe abdominal pain, severe bleeding, and palpable uterine defect with palpable fetal parts will be there. It is completely and clinical diagnosis. Immediately start on major hemorrhage protocols, which the time till you have the blood products with IV fluids, and refer to the gynecologist to be taken up in the operation theater. Breast conditions, two breast conditions you need to be aware of: mastititis and abscess. Mastititis is nothing but inflammation, what you're seeing. Mastititis is nothing but is the inflammation what you're seeing here. This inflammation is commonly seen during the breastfeeding time. So this inflammation commonly seen during the breastfeeding time. Abscess. What is abscess? Abscess is a complication of mastitis where there is a pus accumulation which is present here. Whenever there is an abscess, it needs a drainage. So you need to refer to the surgeons here. So there will be a mass which will be quite tender, and there might be a point where pus might be oozing out, and there will be localized rise of temperature also will be presenting in those conditions. So what you'll be doing here? You will be referring to the breast surgeons because it requires an drainage. Most commonest organism causing this is Staph aureus, both for abscess as well as the mastitis. What about breastfeeding? Do we need to encourage continue breastfeeding or stop the breastfeeding? You will encourage them to continue breastfeeding because this will prevent the milk stasis. So encourage them breastfeeding. Breastfeeding is not contraindicated in mastitis, not contraindicated in breast abscess. When do we refer to an breast clinical referral or breast clinic? Whenever you have a breast lump, it might be a tumor. We do not know whether it is cancerous or not. Whenever there is an inverted nipple and it is a new inverted nipple you are having, whenever there are skin changes over the breast, especially orange skin peel, the dimples, what you see on the oranges, if that kind of skin changes are there, it might be suggestive of a cancer. You need to refer to the breast clinic. Emergency contraception. Emergency contraceptions, they come as an early morning pill. Basically, they had an intercourse and they want to prevent the pregnancy. That is known as emergency contraception. There are two tablets which are available in UK. One is known as levonorgestrel. Another one is known as uliprestrol. Levonorgestrel can be given up to 72 hours, that is up to 3 days. And up to 5 days uliprestrol acetate can be given. Both acts by inhibiting ovulation. Okay, both acts by inhibiting ovulation. The 72 hours and 120 hours I have said after having an unprotected sex. Both acts by inhibiting ovulation. If ovulation has already happened, these drugs will not be effective. Uliprestol is specifically contraindicated whenever the patient is having severe asthma. When do you call it in severe asthma? Whenever the patient is having to take oral steroids to control the asthma, then we call it as in severe asthma. And both these drugs, that is levonorgestrel and uliprestol, are ineffective in enzyme-inducing drugs. Enzyme means I'm talking about cytochrome P450. Okay, whenever they are on drugs which induces the cytochrome P450, this results in increased metabolism of both levonorgestrel and uliprestol, and they will not be effective. And they will not be effective if the patient is obese. Also, obese means BMI being more than 30 kgs per meter square. So let us just have and look at the enzyme inducers. You need to be aware of multiple times tested in the exam. Enzyme means cytochrome P450 I'm talking about. This drugs you need to be aware of is carbamazepine, phenytoin, phenobarbital, rifampicin, alcohol. All of these are enzyme inducers. When are these drugs contraindicated? Contraindicated if they have severe liver disease, porphyria, migraine, severe malabsorption syndromes, it is contraindicated. You're given a pill, but unfortunately, they are vomited within 2 hours. What do they need to do? They need to take one more pill. If they're vomited after 2 hours, you got already observed, they need not worry about. So within 2 hours, if they vomit, tell them you need to take one more pill. Other what we can use is copper intrauterine contraceptive device. It is the most effective device. Okay, remember that it might be the most effective, but not 100%. Same thing holds good. These are all around 90 plus effective they are, but they are not 100% effective to prevent the pregnancy. What is the mechanism of an intrauterine copper device? It prevents the fertilization in the ova. It also inhibits the implantation. So after ovulation, can you use it? Yes, you can use it because it prevents the fertilization in the ova and inhibits the implantation. Can be inserted up to 5 days after having unprotected intercourse. Remember, these are not 100% protective. That means it cannot avoid pregnancy 100%. If they at all develop and lower abdominal pain, it can be an ectopic pregnancy. Okay, for that particular reason, they need to come back to the emergency department whenever they have an low abdominal pain, because we cannot say that they are not got pregnant. We cannot say that that pregnancy will not be an ectopic. So they need to present to the emergency department. Women who are using hormonal contraceptions are advised to use additional contraception for 1 week post levonorgestrel and additional contraceptions to 2 weeks post uliprestrol. So if they want to continue an hormonal contraception, it will not be effective after taking levonorgestrel for 1 week, and for 2 weeks after taking an uliprestrol. They need to use other contraceptive methods like condoms, barrier methods. They need to use it. Sometimes they might present to the emergency department when the OCP pills are missed. Oral contraceptive pills, they say, Doctor, I'm missed an OCP pills. I'm worried what needs to be done. So it depends on what kind of OCP pills they are taking. Are they taking a combined pill or are they taking only progesterone only pill? First, let us see the combined pill, what they are taking. If one missed pill is present, or two or more missed pills are present, then it depends on what needs to be done. For both this condition, where one pill is missed or two pills are missed, for both this condition, you give one pill as soon as possible. Okay. So as soon as possible, give one pill. Next pill, you take it whenever you take it. Early morning, I take it at the time what your regular schedule is. One tablet, you take it now itself immediately. If you have missed one pill, you're still protected against the pregnancy. Emergency contraceptive pills like an levonorgestrel or uliprestrol will not be required. If you have missed two or more pills, then you are not protected against the pregnancy. Additional contraceptions will be required for next 7 days. So you missed it today. For next 7 days, additional contraceptions like condoms you will be using. What about if they had an sexual intercourse? If they had a sexual intercourse in past 7 days, then they can get pregnant. So what do they recommend? Early emergency contraceptive pills they need to take. So in past 7 days, since the time they have missed the pill. If they had an sexual intercourse, then they need to take an emergency contraceptive pill like a levonorgestrel, or they need to go ahead with an IUD device. Missed progesterone only pill. If they missed a progesterone only pill, it depends on the hours, how long they are, since you have taken the last dose. You're supposed to take it at 10 a.m. Now it is 4 p.m. That means it is more than 3 hours. You're supposed to be taken at 1 p.m. You have taken it at 2 p.m. That means delayed by less than 3 hours. So this is delayed by less than 3 hours. Take an emergency pill. Next one at the normal interval holds good for any missed pill. So generic thing. If it is less than 3 hours, you're protected against the pregnancy and you need not require any emergency contraceptive pills. So do not worry. So this part is same. If you have missed one combined pill, or if you have missed by taking less than 3 hours delay for taking and progesterone only pills, both are same. Next one, what you are having, they're delayed taking for more than 3 hours. Then they're not protected against pregnancy. They need to use additional contraception for next 2 days. From here, next 2 days, additional contraception like condom they are using. Emergency contraception if unprotected sex during this time. That means were supposed to take it at 10 a.m. Okay, they have taken it at 4 p.m. That is more than 3 hours it has been. In this duration, if they had an sexual intercourse, then they need an early morning pill, that is emergency contraception like uliprostol or no, uliprostol or levonorgestrel or intrauterine device will be required. If a woman vomits within 2 hours of taking an OCP, then they need to take another OCP. Same thing as we discussed for an emergency contraceptive pills. If they are having a diarrhea, okay, will the OCP will be helpful? Yes, OCP will still be effective unless the diarrhea is severe and it is lasting for more than a day's time. In breastfeeding women, do you suggest a combined or progesterone only OCP? Progesterone only OCP is preferred. Combined OCP is not preferred because it decreases the milk secretion and it predisposes the female for increased risk of venothromboembolism. Few of the sexually transmitted diseases, again, we are sexual health we are talking about here. Primary syphilis and chancroid. Primary syphilis usually presents with an canker. That is nothing but ulcer. Chancroid is nothing but again an ulcer. How to differentiate between the two? A primary syphilis causing an ulcer, usually it is painless. A chancroid is painful. That is important to pick it up from the stem of the question. If they mention a painful, then it is a chancroid caused by an gram-negative hemophilus directly, commonly seen in HIV positive patients, and they will be having lymphadenopathies and palpation, it will be tender. You treat it with azithromycin or ceftriaxone. A primary syphilis, if you are suspecting, primary syphilis, usually if you take a proper history, it will be a nodule. This nodule will burst open, resulting in formation of an ulcer like this, what you are seeing in the picture. They'll be having lymphadenopathies and they will be painless. And this ulcer will be painless, nodule also will be painless. It is caused by Treponema pallidum and the treatment is benzyl penicillin, what you'll be giving, like the treatment of the syphilis. Genital herpes. Genital herpes, usually they present initially with severe itching. In the groin region, they'll be having severe itching. You'll not be seeing the vesicles, what you're seeing here. This will not be seen in the initial stage. Just they'll be having severe itching. They will be present. No vesicles will be seen. Severe itching will be present. Okay. Later on, what will happen? Later on, these vesicles will come up. Because you're itching continuously, it can get infected, resulting in formation of pustules can happen. Treatment is oral acyclovir. It is caused by herpes simplex virus 2. Bartholin cyst, abscess, and CA. How to differentiate and how do you know it's a Bartholin cyst? Bartholin cyst or Bartholin gland is usually present at 8 o'clock position and 4 o'clock position. It's the clock I'm talking about. 8 o'clock position and 4 o'clock position it will be present on. If this Bartholin gland gets obstructed, result in formation of a swelling. This is known as a cyst, Bartholin cyst. If this cyst gets infected, how do you know it is infected? It is hard, red, and painful to palpate and has associated lymphadenopathy. Then it is infected. If it is infected, then you're thinking of an abscess. When do you think of an cancer? Associated symptoms, what do you need to see? Where there is a significant weight loss is present in an elderly individual and it is a painless what is present, then think of an Bartholin cancer. In all these circumstances, if it's an abscess, requires a drainage. Okay, if it is a cyst, you can just refer to the OBGYN to follow up with. If it's in Bartholin cancer, you are suspecting, again, OBGYN to further evaluate. Few other conditions also you need to be aware of, which can come to the emergency department. Most of the time, they go to the GP, but they can present to the ED department also if they do not get an appointment with the GP. So what are the presentations? Is the vaginal discharge I'm talking about. A cottage cheese discharge. Remember that this is odorless. Okay, non-odorous, odorless it is a cottage cheese discharge. Then most likely it is a candida infection. You treat it with oral fluconazole. In pregnancy, you can give clotrimazole preceseries. In breastfeeding or young individuals, you prescribe them topical clotrimazole. That should be sufficient. How do you diagnose? Diagnose by making an KHO prep. Okay, KHO prep. That's nothing but in a slide, KHO prep, what we'll be doing, and you will be seeing a lot of hyphae under microscopy. That will be suggestive of a candidal infection. Frothy yellow greenish discharge. The key terminology is frothy yellow greenish discharge. Then think of an trichomonas infection. Trichomonas infection, usually it will be having a wet mount with a motile flagella organism. So it will have an flagella and it will be moving around. So wet mount, you get it done. Treatment is metronidazole. Has a very bad smell, a fishy odor smell is present. Then you're thinking of a bacterial vaginosis. On a wet mount, you see an clue cell. If they're asymptomatic, do not treat them. If they're symptomatic, tropical or oral metronidazole, you can treat it with. White, yellow, or gray color discharge if they are having. It's a chlamydial infection. If it is greenish discharge, you are thinking of an gonococcal infection. Both of this are gram staining is required. So you take a swab for gram staining and cultures. Chlamydial infection is treated by an doxycycline. In pregnancy, doxycycline is contraindicated. That's why you are using azithromycin. Gonococcal infection, a single sort of ceftriaxone given IM should be sufficient. It's genital herpes that is usually caused by herpes simplex virus 2. They initially have a burning sensation, severe itching. Later on, they develop vesicles as we have discussed, and they can turn into pustules. It's completely a clinical diagnosis, doesn't require any investigations. You're treating with an oral acyclovir. So whenever you're suspecting a sexually transmitted disease, do not start on any treatment unless they are in shock or requires an admission. If they do not require an admission, just refer them to the GUM clinic, which stands for Genitourinary Medicine Clinic. Just refer to them, because whenever there is a sexually transmitted disease, you need to track the partners, sexual partners, and usually get the sexually transmitted disease screening done, like HIV and all screening needs to be done. This is best done in Genitourinary Medicine Clinic. It is very difficult to get it done from the emergency department. If they refuse to go to the GUM clinic, that's when you prescribe the antibiotics. Otherwise, it is always suggested that if the patient is stable, then do not immediately prescribe the antibiotic. Just refer to the GUM clinic. They will do everything from taking the swabs to tracing the partners, starting them the antibiotics, uh, counseling them regarding the contraception. All those things will be done in Genitourinary Medicine Clinic. Now we'll be going into the questions. There doesn't seem to be any doubts. If you have doubts, you can type it in the meeting chat, what is present there. We are having a 29 years old female, presents with fever and fatigue. 7 days back, she delivered a healthy male baby. The heart rate is on the higher side. Blood pressure is on the lower side. Saturation is also on the lower side. What is the diagnosis they are asking? So it is a postpartum. Postpartum, how many days? It is 7 days. If it is more than 24 hours, what we start thinking of? We start thinking of an infection in this individual. This is an infection. So I call it as an sepsis because it seems to be severe infection with tachycardia and hypotension. Because of hypotension, I can call it as a shock also. That's why I'm picking up as an septic shock syndrome here. There is nothing that suggestive of an uremic shock usually seen in renal failures. DIC, we need to have blood reports to really comment on DIC. Obstructive shock, we call it as an obstructive shock if it is an cardiac tamponade or an intention pneumothorax. In those conditions, you see an obstructive shock. Doesn't seem to be anything like an obstructive shock. Hemolysis, we are not sure. We do not have a peripheral smear to really comment on the hemolysis at all in this condition. A 8-week pregnant lady has an vaginal bleed. Okay, 8-week pregnant lady has an vaginal bleed. She was diagnosed with an inevitable abortion. Okay, she went and visited OBGYN, diagnosed with an inevitable abortion. So she comes to the ED department and she has a low blood pressure. You immediately start the IV fluid. What is the next step? Actually, you shouldn't have started immediately. The next step should have been to do a speculum examination and look for products of conception. Are they stuck in the cervix? If they're stuck in the cervix, you need to remove it immediately. Most of the time, especially in first trimester, whenever there is an abortion, you're suspecting a cervical shock rather than an hemorrhagic shock. Again, same question. Sorry. Yeah. Again, similar question. You have an 8 weeks pregnant lady, vaginal bleeding, inevitable abortion. They are seen the OBGYN, diagnosed with inevitable abortion, present to the ED with hypotension. What is the next best step they are asking? Next best step here is remove any retained products of conception from the cervical os because they're not given. So you do a speculum examination, look for the cervix. Are there any products of conceptions? Use a Megel's forceps under direct vision, remove it. That should be the steps. A 32 weeks pregnant lady presents with a vaginal bleeding. The mother is Rh negative. The father is Rh positive. What is the next step in the management they are asking? Is it more than 20 weeks of gestation? Yes. Do we need to give? It can be placenta previa or placenta abruptia or placenta previa or vasa accreta. So we do not know the cause here. But we know it is a sensitizing event. If it is a sensitizing event, what we need to do? We need to give an anti-T immunoglobulins. Nowhere in the stem of the question it says that the patient is immunologically unstable. So none of this apply here. Reassure and discharge. No, not giving before anti-D immunoglobulins. You cannot discharge or advised to follow up with GP. A pregnant woman met with a road traffic accident. Blood pressure is on the lower side. How to assess the viability of the fetus? So whenever it is in critical emergencies, like in polytrauma case you are having it, if the fetus is more than 20 weeks of gestation, polytrauma or let it be in cardiac arrest, if the fetal age is more than 20 weeks of gestation, you need to think of saving the fetus also by doing an immediate resuscitative C-section and deliver the fetus. Especially in the cardiac arrest, we have already learned that within 5 minutes, deliver the kid. How do we know if it is more than 20 weeks of gestation or not? That means, how do you assess the viability of the fetus? Indirectly, they're asking it by palpating the fundal height. If the fundal height is around pubic symphysis, it is 12 weeks of gestation. If the fundal height is around umbilicus, it is 20 weeks of gestation. If it around xiphoid, then it is 36 weeks of gestation. So here we are worried about 20 weeks. So if the fundus is below the umbilicus, indicates an unviable fetus. That means you just concentrate on the mother here. Do not concentrate on the fetus. If you do in C-section also, the fetus unlikely to survive because it is only 20 weeks. It is not matured at all. You cannot you cannot make this fetus survive at all in an external environment. So just concentrate on the mother. Check the fetal heart rate. No, that will not be helpful. Perform PB examination. You shouldn't be doing in critical emergencies. Abdominal ultrasound by an obstetrician specialist. Again, time consuming it is. Just by palpating the fundal height, that should be sufficient. Palpate the part of the uterus in the abdomen indicates an viable. No, that is also not. So first option is the right option. It has been tested multiple times in the exam, including in Jan 2025 diet. A 30 weeks pregnant, flushing, nausea, severe headache, and double vision they are having. Never had any antenatal checkups before. What is the most probable diagnosis? Whenever they say they're having headache, double vision in a third trimester, especially more than 20 weeks of gestation, think of an preeclampsia. This similar presentation can be for an cavernous venous thrombus also. But preeclampsia is much more common than an venous thromboembolism. That's why always pick up an preeclampsia. One more clue for you to pick up an preeclampsia here is never had an antenatal checkup. That means never checked the blood pressure. Whether this patient had a gestational hypertension or not, we do not know. So the right answer here is preeclampsia. A 8-week pregnant lady presents with severe nausea and vomiting. IV fluids and metoclopramide is been given. Spasms in the neck are noted. What is the drug to be given to alleviate her symptoms? The spasms what are seeing in the neck. So if you remember our previous chapters in the psychiatry especially, what is this spasms? These are spasms because of the side effect of what drug? Metoclopramide resulting in acute dystonia. So acute dystonia this patient is having. What is the drug of choice? Procyclidine. Procyclidine is the drug of choice. So you're choosing procyclidine. Benztropine can be given, that is also drug of choice, but it is not available in the UK. Diazepam can be given or lorazepam can be given, but it is contraindicated in pregnancy and it is not as effective as procyclidine and it is not advised in a normal individual also. Dose is 5 mg IV, while discharging few tablets of procyclidine also needs to be given. A 30 weeks pregnant lady, she complains that water is broke. Which prophylactic antibiotic needs to be given in this patient, they are asking. So the prophylactic antibiotic which is to be given whenever there is water is broke means there is premature of rupture of the membranes. According to RCOG, they recommend to give an erythromycin. So this is a difficult question. RCOG has recommended to give an erythromycin. That's why erythromycin. A similar question can be tested in the exam. So be aware, if there is a premature rupture of the membranes, you are giving erythromycin. A 23 years old female has a diffuse abdominal pain. LMP was 6 weeks ago. So what am I suspecting? An ectopic pregnancy. There's a tachycardia, tachypnea, blood pressure is in the borderline. Urine pregnancy test was not done as the patient was not able to give the sample. Fast scan you are doing and shows no free fluid in the medicine's pouch. What is the best next step they are asking? What you will be doing here? So whenever there is an ruptured ectopic pregnancy, where do we suspect and free fluid to be? In pouch of Douglas. They have seen only Morrison's pouch. There the free fluid is not seen. Free fluid means blood is not seen. So they need to continue doing the ultrasound examination, including the pelvis, to specifically look for the pouch of Douglas. So option number 2 will be the right answer here. Gynecological team for an assessment, yes, eventually will be required once you make a diagnosis of an ectopic pregnancy, not for the assessment, but for the operation. Catheterize and take a sample for the urine test. That is time wasting here at this point of time. Ideally, you need to get an beta HCG level. Per speculum examination. Per speculum examination, we do not even know whether the lady is pregnant or not, whether it is ruptured or not. CT abdomen in an unstable patient, it is not recommended to shift the patient out of the resuscitation bay. 36 weeks pregnant lady complains of low abdominal pain and vaginal bleeding. Previous history of pregnancy, she had placenta previa. What is the diagnosis? Previous history of placenta previa is a risk factor to having placenta previa. But the trick here is having an abdominal pain. Anyone has a pain, always pick up an placenta abruptio over and placenta previa. Doesn't matter if there is a previous history of placenta previa or not, because the pain is present. A 31 weeks old lady is brought to the emergency department, complaints of lower abdominal pain. LMP is 6 weeks ago. Tachycardic, hypotensive, tenderness in the right iliac fossa. Ultrasound scan shows a ruptured ectopic pregnancy. What is the next step? The patient is hypotensive. So what we need to do? Give IV fluids first. Once you are given IV fluids, then you will be referring to the OBGYN. If you directly refer to the OBGYN, it might be too late. The patient might go into cardiac arrest if you do not give IV fluids. Postmenopausal woman has presented with a PV bleed on and off since few weeks. Next step. Whenever a postmenopausal woman presents with a PV bleed, what are we suspecting? It might be an endometrial CA. So what we need to do? We need to refer to the gynae team. So urgent OPD referral to the gynae team. What they do? They get an ultrasound scan done to see the thickness of the endometrium. If it is significantly on the higher side, they get a biopsy done and send it for histopathology to see whether it is a cancer. A 36 weeks pregnant lady with a bleeding PV. Previous ultrasound scan shows that the placenta is low-lying. Tenderness is noted over the abdomen, likely diagnosis. Tenderness is the key terminology. More than 20 weeks of gestation. So it is an antepartum hemorrhage. As there is a tenderness, I'm picking up placenta abruptio as the right diagnosis. Young obese female, unprotected sexual intercourse last night. She is seeking for an early morning pill. Which statement is correct? Contraceptions cannot be achieved after ovulation. That is a false statement. You can use intrauterine copper device and use it. So it is a false statement. Ask the patient to return to the ED if she develops an pain abdomen or bleeding. Yes, it can be ectopic pregnancy. This is one of the things what we have learned. The patient does not need additional contraception if vomited within 2 hours. No, needs it. If they vomited after 2 hours, doesn't need a contraception. IUD is the best option. It is the most effective one. Best option depends on the individuals. Okay, so IUD is not always the best option because it is an invasive procedure. It needs medical personnel to insert it. Early morning pills, they can just swallow it. Uriprostol is the best option here. No, the patient is obese. Uliprostol will not be effective in this individual. Okay, it's not the best option again. You cannot just say the best option here again in this manner. Young lactating female complains of pain in the right breast. She is breastfeeding. Tenderness and swelling are noted over the right breast. So what is the most likely cause here? Tenderness, swelling, you're suspecting either a mastatitis. Swelling can lead to an abscess. Also, it's difficult to differentiate. Both mastatitis as well as the breast abscess, the most commonest organism causing this is Staph aureus. A 29 years old obese female requesting for an emergency contraceptive pill. Sexual intercourse with her partner was 5 days back. Okay. She denies taking any illicit drugs. Which of the following will be the most appropriate here? Now we are talking about most appropriate. The difference between the 14th question and the 16th question in the framing of the question. Here they are asking what is the most appropriate management for this patient. Here they are just asking that what statement is correct. They're not talking about the patient at all. That is the differentiating factor. So now I am thinking about the patient, what is there. She is an obese. If she is obese, I cannot use levonorgestrel or uniprestol acetate. Okay, it will not be helpful in this individual. No contraception required. That is a false statement. Do beta ECG and refer to the OBGYN. Soon after this, beta ECG will not be. It has to get implanted. Then only the beta ECG will be helpful. So this is not. So the best is insert and copper T device for this individual. So remember, do not get confused between 16 and 14. 14 doesn't ask about the scenario at all. They're just asking about the statement. 16th is asking about the scenario, the stem of the question, what they are given. A 34 years old female has an vaginal bleed, takes regular OCP pills. Vital parameters are within normal limits. Abdominal examination is unremarkable. Urine pregnancy test is negative. What is the most appropriate next step? So, why she is having bleeding? We do not know. Sometimes it might be because of an OCP. Sometimes it might be because of a fibroid. It might be because of an polyp. It might be because of an endometriosis. There are various causes of vaginal bleed, especially in this age group. So just tell them to follow up. Why I am confidently telling them to follow up? Because the vital parameters are stable. You can just follow up with the OBGYN. That should be sufficient here. If you're suspecting a sexually transmitted disease, then gum clinic, stop OCP. We do not know whether the OCP is causing here or not. Immediate ultrasound scan doesn't make sense. Outpatient ultrasound scan also doesn't make sense here in this scenario. Which of the following will help you to determine the amount of anti-D to be given? It is the Clohos test which will be helpful for you to determine. A 32 years old female has come to the ED department seeking advice on contraception. 5 weeks postpartum and breastfeeding her kid. Seizure disorder and is on carbamazepine. Breastfeeding, combined OCPs, I cannot give it. Exclusive breastfeeding is around 70 to 80% protective, not 100%. It is very bad contraception. No contraception is required because she is delivered. Again, a false statement. Now we can give an levonorgestrel or IUCD. Levonorgestrel can be given, but the problem is the patient is on an enzyme inducer. That is a carbamazepine, which is an cytochrome P450 enzyme inducer. So you rule out an levonorgestrel. So best will be an copper T device. A 28 years old female delivered an healthy boy in the emergency department. It was a normal vaginal delivery. Soon after delivery, her vital parameters are on the lower side, bradycardia, hypotension. What's the most likely cause for the above finding? So after delivery also, there are few products of consumption like placenta and all needs to come out. If they get stuck in the cervical os, it can cause increase in vagal stimulus. Increase in vagal stimulus causes bradycardia and hypotension. That's why I'm picking up an vagal stimulus here. Why I'm not picking up a septic shock? In septic shock, you expect tachycardia to be present, not an bradycardia. That's why I'm not picking up a septic shock here. Postpartum hemorrhage. Yes, it can be a postpartum hemorrhage, but again, you see an tachycardia, not bradycardia. Ruptured uterus is completely different, and obstructive shock is a completely different diagnosis. A 32 years old, 28 weeks pregnant, she's complaining of headache. This is her first pregnancy. Blood pressure is on the higher side. Pedal edema is noted. So what are we suspecting here? We're suspecting an severe preeclampsia. To be more precise, a severe preeclampsia I am suspecting. With the following helps you with the diagnosis. For a preeclampsia, proteinuria should be present. That's why you're doing an urine routine to find out the proteinuria. A 32 years old female presents with an occipital headache, vomiting, and blurring of the vision. She's at the 30th week of pregnancy. What is the likely diagnosis they are asking? Again, this is a diagnosis of a severe preeclampsia we are thinking, because this is more commoner in a pregnant woman. All others also can cause an occipital headache, vomiting, blurring of the vision. For example, SAH, yes, can cause intracranial bleeding, yes, space organ lesion, yes. But as it is the lady is pregnant and young, we are most likely thinking of a preeclampsia. Eclampsia is a seizure, so straightforward you can rule it out. A 36 weeks pregnant, previous scans have confirmed an intrauterine pregnancy, experiences severe continuous abdominal pain. Abdomen is tender and uterus feels firm. Further assessment of the patient should you take while in the ED department, they're asking. So what do you need to do? First of all, what is the diagnosis here? We are thinking of an abruptio. In abruptio, what did I tell you? Abruptio will not correlate with the amount of PV bleed, because most of the time it is concealed hemorrhage. So what needs to be done? Point of care ultrasound scan, you get it done and find out how much bleeding is present. So that is important to find out. And it also helps with the diagnosis of abruptio placenta, confirm diagnosis here. A 21 years old complains of discomfort in the vaginal area accompanied with greenish discharge, likely organism. It's a green color discharge. That's why we are thinking of an gonorrhea. If you're thinking of any other diagnosis, different things we have learned about, for example, fishy odor is present, then bacterial vaginosis, we have frothy yellowish green color, then trichomonas. Genital herpes, if you're thinking about, it is a severe itching and vesicles which are there, which can turn into the pustules. 8 weeks pregnant lady, vaginal bleeding, diagnosed with an inevitable vagina, bradycardia, hypotension. What's the likely cause of this finding? This is a cervical shock because of increased vagal tone. Multiple times discussed the same question, similar question, sorry. 34 years old married woman present to the ED department with complaints of discharge from PV. Purulent, gives a history of intercourse with an unknown person 1 week back. Next step of management. What has happened? Purulent PV discharge, most probably because of a sexually transmitted disease, because they had an intercourse with an unknown person. So whenever you are suspecting a sexually transmitted disease, what needs to be done? You need to refer to the gum clinic. Okay, so referring to the gum clinic serves as a single point where you can trace the partners. You can counsel them of a safe sexual practice. You can evaluate them for sexually transmitted diseases, including an HIV, and start them on the antibiotics. Everything can be done at the gum clinic. 34 weeks of gestation, complaints of headache, nausea, vomiting, abdominal pain. Blood pressure is on the higher side. On palpation, there is a right upper quadrant tenderness is also noted. What is the diagnosis here? So, first of all, headache, nausea, vomiting. What are we suspecting? We are suspecting and severe preeclampsia with the blood pressure being on the side. So, severe preeclampsia the patient is having. But tenderness in the right upper quadrant where the liver is present. So liver is getting damaged. In what complications do the liver get damaged? They usually when they develop an HELP syndrome. So the right diagnosis here is the HELP syndrome, not severe preeclampsia. Because the key terminology here is involvement of the liver. If the liver is getting involved, what do you need to think of? It is an HELP syndrome what they are having. It is a severe complication of a preeclampsia. The patient is having a HELP syndrome. You need to likely diagnosis you are having it. One of you is asking no labs. There's no labs to diagnose a preeclampsia also. Proteinuria, they are not mentioned here. Okay, so we are guessing with the amount of what is given, what is the most likely diagnosis, not an definite diagnosis. 12 weeks of gestation, presence with an vaginal bleeding, hemodynamically stable, her blood group is B negative. Next step. Okay, no intervention is required. Administered 250 internal units of anti-D immunoglobulins is the right answer. 500 international units will be given after 20 weeks of gestation. Perform Kleho's test before deciding this is done. You usually give anti-D immunoglobulins after 20 weeks or after the delivery. You give 500 international units, then do an Kleho's test. Administer vitamin D only if the husband is Rh positive. Theoretically, it's true, but practically it is not advised because he may not be a biological father. He may not be available immediately. This is time sensitive. You need to be giving as soon as possible. So the right diagnosis here is giving or administrating 250 internal units of anti-D immunoglobulins. A 9 weeks of gestation, nausea and vomiting it is present with, unable to tolerate orally. First line of antiemetic of choice according to the LINES guidelines. First line of drugs. Promethazine, cyclizine, doxazomine, and pyridoxine. All are first line of drugs. So out of this, which is the first line of drugs mentioned here? Cyclizine is given. Okay, cyclizine is the right answer. So remember two drugs which is very commonly used. Either they use in cyclizine or doxalamine and pyridoxine combination they use it. These are the very commonly used first line of drugs. Second line of drugs commonly used is ondansetron. Third line, what we use is hydrocortisone, but we do not use it. We need to take OBGYN's advice before we give an hydrocortisone. A 24 years old woman presents with painful swelling in the groin region. A history of multiple sexual partners. Refuses to visit the gum clinic. On examination, the patient is stable. Swelling appears tender and fluctuating. Most appropriate management plan for this patient. It is tender and fluctuating what you are having. So what are we suspecting? There is an infection, definitely. Okay, definitely it is an infection. And we are thinking this infection mainly because of a sexually transmitted disease because of the mention of multiple sexual partners. Ideally, they need to go to the gum clinic. They are refusing to go to the gum clinic. So you need to treat the patient in the ED department, take a swab, prescribe ceftriaxone and doxycycline because you're suspecting in sexually transmitted disease. Most common is gonococcal and chlamydial. You're covering both by giving ceftriaxone for gonococcal, doxycycline for chlamydia. That becomes the right answer. Admit for IV antibiotics. The patient is stable. Why do you want to admit for IV antibiotics? Discharge with GP follow-up, no immediate treatment. This patient doesn't want to go to gum clinic. What's the guarantee they'll go to the GP clinic and agree for the GP clinic? Oral metronidazole and co-amoxiclav, it is not the preferred ones. And you need to take the swabs before you prescribe the antibiotics. Advise symptomatic management review after 48 hours. No, you're suspecting and sexually transmitted. This is better you start the antibiotics, start evaluating them here in the ED department. So that ends the OBGYN. Anyone has any doubts, you can ask me